As the challenges of frailty escalate in an ageing society, leading scientists in the field participated in a Nestlé Nutrition Institute workshop in Barcelona. Their quest? To advance know-how about the biological causes, clinical characteristics, and evolving intervention strategies of this complex geriatric syndrome.
I thought we got the right speakers to talk on the right topics for where we are in this quest to understand frailty and to think about interventions that can be developed in frail older adults.
The shared goal of this meeting is to capture the various dimensions of frailty so that we can devise better patient-centric integrated interventions.
Within a few years, frailty will be on the upfront for both research and implementation, not just in Europe, I think on a global scale in an aging society.
We started yesterday afternoon really with some excellent talks on the biological basis of frailty. It's from that basic discovery that potentially new therapies and treatments can be developed.
What we've discovered in our recent work is the fact that poor diets can actually increase the abundance of these damaging cells in the body called senescent cells. They're the rotten apples that spoil the cart. And what we also learned is that exercise, even in the context of a poor diet, is potent enough to decrease the burden of those cells as we get older.
So over time, mutations and deletions and also shortening of the telomeres makes the DNA more vulnerable to damage and also gives an altered signaling of proteins as we age that can further exacerbate the aging process.
SHARE study is the biggest study that we had in Europe, and this study is focused on pre-frail, frail, and robust, and we can show that frailty is reversible.
There's a great understanding of what the clinical presentation or phenotype of frailty is now, and we're beginning to really realize that it's driven in part and to a large extent by weakness and this thing we call sarcopenia.
Frailty is a more complex outcome from sarcopenia.
But we're also learning that there's a tremendous amount of overlap with the cognitive decline with aging.
There's a new dimension to frailty, and that is the psychological aspect of frailty, which would include mood and cognitive features to it.
Crucial point is how we screen and assess for malnutrition, having this very close link to frailty. I think the nutrition assessment test, having questions in about mobility, depression, dementia, captures a lot of the very important items in the frailty syndrome.
We know a lot about inflammatory mechanisms, but what is added now are also the role of neuromuscular distortions and genome instability, apoptotic pathways, which will facilitate new treatment modalities.
Very exciting sort of recent intervention trials that span the domains of physical activity and exercise interventions and nutritional interventions. But we haven't heard too much yet about pharmacological interventions, and I think that work is going to start to come forward.
The key is to do integrated interventions.
So what research tells us today, we have 3 promising strategies to prevent frailty, and this is a high-quality protein, vitamin D supplementation, and exercise.
Resistance exercise, together with endurance training.
If we give vitamin D to seniors, we can improve strength and balance, and we can reduce the risk of falling.
Exercise and nutrition are particularly important in physical frailty. Also, early studies indicate that it may be the best that we have at this point for intervening in psychological frailty.
For some people, it's very important to start early in life with some of these interventions.
The most important topic is to implement frailty into clinical practice. What we were able to build in Toulouse at the Gerontopole is one of the first frailty clinics where the GP, the health professional, family practitioner, they refer to us, older people, for frailty.
It links the person living in the community, seeing the GP, then being sent to the specific clinic.
We prevent frailty, we improve quality of life.
Health span is the period of our life that's active and productive, not burdened by the presence of disease, disability, or frailty.
Economics of how these interventions can reduce healthcare costs is going to be really important for future studies and to convince regulators and payers.
If we do nothing, in 5 years we will have to double our facility.
The next step is really to create awareness for those who see most of frail people. These are the GPs.